This meeting will be recorded. All right, good afternoon, everyone. Thank you so much for joining. My name is Ihan John, and I'm the president of the Southeast chapter. Before we go into Dr. Nadkarni's talk, we'll start our meeting by stating the mission and the vision of the chapter. The mission of the chapter is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. The vision of the chapter is that all critically ill and injured persons in the Southeast region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. I would like to make a few announcements from the chapter about upcoming events. First, we'll be hosting an ultrasound course on September 19th, one day prior to our Southeastern Critical Care Summit at Emory University Hospital. Registration costs are available on the slide. And if you're a chapter member, you may submit an application for reimbursement for a chance to take it for free. More information and links are available on email communication that was sent out last week, as well as the QR code on the slide. Also, 8-hour CE credits will be available for participants. Next, Southeastern Critical Care Summit will be held at Emory University Hospital on September 20th. Please scan the QR code for our agenda. Some programs include critical care courses, bite-sized teaching, and pro and versus con debate. We're excited to co-host our 5K called Stomp Out Sepsis at Lilburn City Park on October 5th to raise money and awareness for sepsis. All proceeds will go to Sepsis Alliance, so please join us in running or walking for a great cause. More information can be found at www.stompoutSepsis5k.com. Please save the date for our next bite-sized lecture on October 23rd on the topic of ECMO and respiratory failure. This talk will be hosted by Dr. Dave and his team at Emory University Hospital. Registration link will be sent out soon. Lastly, please follow us on social media. And today's lecture will be available on our YouTube channel later on. Also, if you have suggestions for topics or speakers for next year's lectures, please email us. We're very excited to have Dr. Vinay Nadkarni speak to us today on Green ICU sustainability. If you have any questions during the lecture, please utilize the chat box and we'll have our Q&A session at the end. Now, it is my pleasure to introduce Dr. Nadkarni to you. Dr. Nadkarni is a professor in the departments of anesthesiology, critical care, and pediatrics at the Children's Hospital of Philadelphia and University of Pennsylvania Perelman School of Medicine. He was the past president of the Society of Critical Care Medicine in 2023. He has worked closely with the Society of Critical Care Medicine, American Heart Association, and Operation Smile International to help lead evidence-based creation, deployment, implementation, and assessment of the impact of contextualized training programs around the world. Now, please join me in welcoming Dr. Nadkarni. Now, I'll hand over the slides to you.
Well, thank you, Ayun, Emily, and Southeast Chapter. It's really great to be here today, and just a pleasure to be here with you. Ayun, are you able to see the slides now?
Yes.
Okay, that's great. And so today I thought we would talk a little bit and sort of work on green and sustainable ICU, what it means. And I'm a little embarrassed to say a couple of years ago, I really didn't have a concept of what was meant by sort of green and sustainable ICUs. Well, I'm talking today, although I was the immediate past president of the Society of Critical Care Medicine, and I have some research grants and scientific advisory board volunteer positions. None of what I'm going to talk about to you today do I have any financial conflict of interest with, etc. But I'm just finding it really interesting to see where we are as a Society of Critical Care Medicine, and also in my own hospital, where we are along the spectrum of sort of awareness and how we're starting to integrate what we do in the ICU with sort of the green and sustainability and carbon footprint of the planet. Our mission, as you know, is to secure the highest quality care for all critically ill and injured patients. And so as we think about some of the, a lot of what we'll be talking about is kind of more is less, and how we right size everything, we have to think a little bit about how it, to ensure that it doesn't impact patient safety and quality. And when we think about emerging concept of a green ICU, North America is kind of in its infancy. Many, like Australia, New Zealand, the United Kingdom, the Netherlands, have been thinking about this for a long time. And what I'll say is that as we were introduced to this by Michel D'Amico and some other folks from within the society, Sheila Mayatra, the president of the Indian Society, Jan de Waal, the European Society, Marlies Oosterman, who's in the United Kingdom, and several others have really been working on this for quite a long time. And so we held a webinar where we kind of, similar to this, where we just started talking about what's going on and why it's important. And when we think about sort of what's going on and why is it important, we have to sort of understand the problem itself. And so if you think about the carbon footprint from healthcare, it's about almost equal to the carbon footprint of all the airplanes that are flown around the world. So it's pretty impressive how much the healthcare system contributes to our carbon footprint, about 20% of all. And then when we think about healthcare carbon footprint, about 20% of it is coming from the buildings, the electricity, and the gas, which is what most people think of when they think about green and sustainable buildings, LEED, and sort of green spaces. But 80% of the carbon dioxide that's generated is coming from good old clinical care. And so when we look at the clinical care component on the right-hand side of this slide, we can see that 10% actually comes from care that could be considered harmful, 30% from low-value care, and about 60% of it comes from our good, effective, efficient care. And so we have a great opportunity to kind of move forward and get rid of the carbon footprint that's coming from 40% of our care contributing to 80% of all of healthcare emissions. And why is this? Well, when we think about how we look at what we do, what you and I do at the bedside, whether it's antibiotic stewardship, whether it's using multi-dose vials instead of single-dose vials, whether it's needlessly putting somebody on isolation when they don't need it and using disposable gowns, gloves, etc. It's not just like recycling that we're talking about, or going from disposable gowns to reusable gowns. The life cycle assessment of everything we do in the ICU setting or in the critical care setting sort of looks at the environmental footprint of that, the entire life cycle around that intervention. So it includes raw material acquisition, the processing and manufacturing of a test tube, for instance, for a blood test, the distribution and transportation back and forth to get it to the lab, or etc., the use, the reuse, the maintenance, the waste management, and the recycling. It's looking at the entire life cycle of the product that we're using, and not just the simple instance of throwing it away or reusing it. And so we think about material production, consumables, procurement, its use, patient, and the waste that it generates. So if we think about like phlebotomy, just think of a simple blood test. We have to get all the materials, whether it's a syringe, a needle, a test tube, the machine. It's raw material extraction, manufacturing, transport, use, and waste, time and time again. Think with me for a moment at the CO2 generation of different types of imaging that we use. Ultrasound uses almost no electricity. almost no consumables and very little electricity. X-ray a little more, CT 10 times as much, and an MRI uses about 20 times the amount of electricity and more consumables than any of those other imaging. And think about how many times a day we do an ultrasound, an X-ray, a CT, or an MRI. It's constant, 24/7 around the clock. And by right sizing and not compromising safety and quality, we can significantly think about substituting appropriately to sort of downsize the amount of CO2 that we are generating while not sacrificing safety or efficacy. Now, in one study, they took and looked intensively at each patient in their ICU, and they counted the amount of disposable products that they used in a day's time. And on average, they used a lot of gloves and a lot of isolation grounds, bed liners, surgical masks, syringes. They identified with simple measures what they could do to decrease the useless or harmful use of these specific products, and found that they had a huge opportunity to not only save money and time, but also to preserve safety and quality while decreasing the carbon footprint. They essentially were able to look at a hierarchy, an inverted pyramid of what they could do in order to decrease their carbon footprint, avoid and prevent unnecessary resource use, reduce and optimize the patient length of stay appropriately, reuse things, recycle things, and dispose of things appropriately. These things, as you can see in the inverted pyramid, have impact on both cost, but also green footprint. And when you think about strategies for how we address this, we can think about the production, the consumables, the procurement, refusing, rethinking, reducing before we actually go in the room and use something, what we're doing during the care of the patient, and then after the use, we can reuse or repair it, we can refurbish, remanufacture, recycle, or appropriately put it in waste. And so we can add and retain value by thinking before, during, and after how we are using these materials. So how do we get started? Well, the Australia-New Zealand Intensive Care Society has really been thinking about this and built a beginner's guide to sustainability in the ICU, where they put into place how to repurpose, reduce, reuse, refuse, rethink, research, recycle, and repair. Sort of this green tree of things that we can do as we're starting out on the journey of sustainability. The European Society of Intensive Care Medicine has produced a number of academic publications that has looked at and identified environmental and humanizing things that we can do. And we can integrate with sort of the climate control folks, those that are doing sort of a lead generation, using elevators that regenerate energy due to the friction on the walls. When we start to think forward with the society about the future of critical care medicine, we can really start to think about what and how we are doing. You all know that the SCCM's mission is kind of broken up into bins like research, education, implementation science, measurement, quality improvement, assessments, with all of those contributing to our mission and feeding back into our spiral going forward. But superimposed on that, maybe exacerbated by the COVID epidemic, we have seen that our faculty, our staff, our providers are sort of thinking about other things, medical resources, safety of themselves, their colleagues, their relatives, talking about the impact of the patients on them and their families, worried about sort of moral distress, thinking about the environment. And so how we sort of integrate this into our practice may have a beneficial effect because we can see that we are moving forward in a positive fashion rather than being bombarded by sort of the enormity of the potential problem that confronts us. Most of the things that we can do to affect this are simple. And they simply make us pause and think and reflect, and then act in a very simple way. I think the COVID pandemic really alerted us to a lot of these issues. And certainly during COVID, we got much better with our isolation practices, protecting ourselves, but we also generated a ton of trash. And now, with the pandemic mostly behind us, we have to start thinking, is it time to right size? Is it time to rethink and explore what we can do to steward our ICU care in a better manner? Of course, the SCCM is responding to various crises. When we think about our recent FCCS, ultrasound, all of the things that we're doing to try to assist in visible crises like earthquakes and floods and conflict zones, SCCM is really good at supporting individuals, teams, societies in these crises, but it's somewhat reactive. We have a system to react, but the climate crisis really requires some proactive action. And in terms of what are we doing to try to improve that, we have projects going on now called the AIRS project, the Africa Infrastructure Project, providing oxygen and sustainable energy, solar energy, to hospitals and centers in 3 countries in Africa, using ultrasound and teaching ultrasound in war-torn areas like Ukraine, developing surviving sepsis campaigns for low-resource centers, and working with other entities like Operation Smile, World Bank, Laerdal Global Health to embed sustainable systems of care in place in low resource settings. For instance, Africa Infrastructure Relief and Support, providing reliable oxygen generation to hospitals and clinical centers in the Gambia, Liberia, and Sierra Leone, providing solar energy for those centers that's renewable, thinking about how to train in austere circumstances like the Ukrainian FCCS and advanced ultrasound courses being trained by SCCM. And then working with other societies like the World Federation of Intensive and Critical Care and the Africa Climate Summit in order to expand the awareness and the bundles that are available to support caregivers, not only at home, but abroad. Think about, in the last year, the 7 SCCM clinical practice guidelines that were released at our annual conference just in January. And you can see that they're very clinically based. But perhaps we also need a clinical practice guideline that addresses green and sustainable ICUs. And in fact, our society has now formed a task force led by Michelle D'Amico and Srinivas Murthy from Vancouver, and they are leading a large task force to look at Green ICU and how we can get a start on Green ICU teams. What can the SCCM do and how will we move forward? They're scouring the published landscape to look where our gaps are and to identify in a green paper what initiatives would make a difference and propose what we might do in terms of developing a lead rating type of scale for each of our ICU practices. Perhaps thinking about things like requiring grant applications to have a section that not only addresses sex as a biological variable and diversity, equity, and inclusion, but also addresses the greenness of the proposal and how it is addressing sustainable issues. The SCCM is looking to provide mentorship for groups and hospitals and ICU teams that want to embark on Green ICU initiatives. And I don't think this was really much of the part of our founding fathers who had great vision and sort of a crystal ball when they founded our society in 1970. But perhaps it's time to take another look and to sort of polish off the rose color on our glasses and think forward about the next generation and how we can support them. When I think about my hospital, the Children's Hospital of Philadelphia, which was the first children's hospital in the United States, when it started, there were 12 beds and 63 patients. And now, as we've evolved, we have 600 plus beds going to 900. There are millions of outpatient visits. There are so many blossoming processes that are consuming and generating CO2 that it's almost unimaginable. And we have to start thinking like an industry about how we can address these issues. When we think about how we deliver care today, it's very complex and getting more and more so. And as we start to unravel the processes that support the infrastructure of our care, we need to really think about how the form fits function, how we can develop work system processes and develop the outcomes inclusive of not just the patient and provider outcomes, professional outcomes, but also our organizational outcomes like green initiatives. The learning healthcare system that we develop should include green and sustainable practice evaluation. And when we think about the elements of our learning healthcare system, we should be integrating these into our metrics to create a resilient and engaged workforce, monitoring not just our patients, not just our providers, but starting to move to monitor the environment as well. When we start to think about the systems that we are using to move fast forward and how we are creating dashboards and displays and how we are doing this in resource-rich and research-constrained circumstances, we can start to link human factors and performance to quality and patient safety. Let's look around our ICUs. Let's see what processes are necessary and unnecessary. Where is the human and the humanity in this photo? And where is it that we will find that we can safely and with quality conserve on our consumables in order to decrease our carbon footprint? As the society moves forward in each aspect, we have opportunity. And so we need to think about how we will add another block in this gear to get the gears going towards a sustainable and green ICU. New mechanisms of communicating, of working together to achieve our goals. We can do it. And methods of monitoring and figuring out how we move from our standard approach of single center, multi-center, general practice, registries, and quality improvement into novel real world techniques with adaptive design and comparative effectiveness that can monitor our progress towards our goal. We're really just at the tip of the iceberg. There are many things in the near future we can implement and more as we move forward. As we think about the efficiency of what we do and how we will deliver care, it is ever changing. And one thing will not change, that seamless critical care without walls will not happen unless we as individuals contribute and try to make a difference. So remember, we should think about what we are doing now and what we can do in the future to create a green and sustainable ICU. We should get together and share lessons learned. We should think about those opportunities we have to improve patient safety and quality, yet decrease our carbon footprint. We should think not only of very specifically what happens in the ICU, but the entire life cycle of those tools and products that we use. And we should think and discuss when we can economize, when we can substitute a less CO2 generating approach to a particular problem. Those changes are within our grasp. They are simple, they are doable, and each individual can make a difference and contribute to the progress we make to our ultimate goal using strategies that make sense for both return on investment and patient safety and quality. Others are doing it, and our society should as well. So as we approach the challenges ahead, green and sustainability is among the top of the list. But when we also look at our opportunities, green and sustainable ICU is also at the top. So with that, let's really think about what we can do together, what people are doing already, and how we can move forward towards a green and sustainable ICU of the future. Thank you. And maybe we can open it up for some discussion.
I'm sorry. I think I was muted the whole time. So sorry. Um, okay, I'll repeat it. So I was just saying thank you so much for that wonderful lecture, Dr. Nadkarni. That was very informational, and interesting and relevant to all the ICUs. I just wanted to read out this one question that I see in the chat box so we can start the discussion. It says, for a healthcare system starting to think about this, it can be very daunting. What would you recommend as the first thing to start with for hospitals or administrators who want to move towards a greener ICU?
That's a really good question and really true. It is completely daunting. I think most of us kind of feel like green ICU is something that the hospital should be doing. Like it's, when they build a new hospital, do they have a garden? Are they building in processes where the wastewater management is and the electricity is efficient? And are they leaving all their lights on at night, et cetera? That's about 50% of the carbon footprint. And it's really important, make no mistake. But when we look at our own function, where do we start? I think like at my hospital, it was kind of like awareness and forming a small ICU team, multidisciplinary, pharmacists, we had nurses, respiratory, the docs, even the unit clerks, etc. And we just started to get together to say, can we pick one project? Can we look at what other people have done, pick one project? I would suggest that probably you're already doing a whole bunch that you don't really realize. So we have some PharmDs on the phone. I think antibiotic stewardship is one great place to start, partly because most hospitals, most of us have sort of an antibiotic stewardship program going on. It's one example where you are looking at patient safety, so you're not doing harm, but cutting back on the number of doses of inappropriate antibiotics that need to be given, or right sizing, going down from broad spectrum 3 antibiotics to a much more specific goal directed, right? And so what that does is, let's say you go from giving 5 days of antibiotics instead of 10 days of antibiotics, and instead of continuing 3 antibiotics, you hone in on 1. Think of all of the vials, think of all of the exchanges that have to happen, all of the buretrols that have to be filled, all of the things that are occurring around that, the number of times that the nurse has to go in, gown, glove, protect themselves if they're going into an isolation room just to check on the pump or to reset it, are all sort of examples of where that program, that stewardship program, could be, if we were measuring the carbon footprint and the potential saved, would already be in place in many hospitals. And of course, we can always do better, but it's probably doing a really good job of cutting down the carbon footprint. But they're not calling it a green ICU program. I don't think you guys are calling it, right, a green ICU program. You're just doing it, but it is having a green impact. So gosh, go ahead and take credit for that. Just measure and then take credit for it, and you're already like halfway there. Sometimes I'm just going to mention some things that aggravated me in my hospital, because I don't know if people are aware. Like, people were generally interested in recycling. We had no recycling bins like available in the ICU. So we got a whole bunch, got the hospital apprised with a whole bunch of recycling bins. Everybody was separating out the trash from the cans and this and that. And then we went down to the loading dock and we found out that they were just dumping all of it into the same old bin that was getting picked up and trashed anyway. And so we thought we were doing this big green initiative, and after all, the hospital was kind of like subverted. Things like only putting needles and soil, like blood tinged things, into the red bins and red bags can really decrease the carbon footprint, because the methodology of waste is very different for the red bags than it is for the standard trash. So those are, maybe I'll stop talking, but those are some examples of ways to kind of get started. And perhaps, like with everything, it's starting to measure what you do. If you just kind of measure and report, you'll find that people automatically, if you display that, they'll want to do the right thing. They'll start to make changes in their behaviors.
Yes, thank you so much for that. And I think you also shared some actionable items through like the document that I can share potentially with the SOSCE's chapter members.
Yes.
Lists all the tips and actionable items, so I can definitely help distribute that for any hospitals that are interested in starting this initiative.
I found it really helpful. It's called the Beginner's Guide to Sustainability in the ICU, and it really is a beginner's guide. It kind of gives really good concrete examples of how not to get overwhelmed and just to get started somewhere.
Yeah, perfect. Thank you so much. And I think we have a few other questions. Next one is, how is the Institute Care of Improvement helping with this effort?
Oh, so they're not doing a whole ton with that. There aren't sort of joint commission and ICI kind of imperatives that I know of yet. There's a group called Practice Green Health, and that organization, which you can just Google, a large number of hospitals are members, and they have metrics and dashboards that are trying to integrate with ICI and with Joint Commission to try to integrate some metrics that would contribute to kind of your Joint Commission accreditation, et cetera. But again, because they've kind of been regarding this as the responsibility of facilities, sort of like the buildings, and not so much the practices, I think they're missing the boat a bit, because we can see that so much of our practice is actually contributing to the CO2. It's not just the buildings themselves.
Perfect. And then another question that I see on the chat box, how would you recommend utilizing dashboards to target areas of sustainability?
Yeah, that's a really good question, because generating and upkeeping dashboards isn't without cost and effort, right? And so we're all like super stretched as it is. That's what I was talking about. There's a fair amount of data that your facilities, like so housekeeping and the electrical and the lights and all that the hospital is probably tracking, because those are facilities kinds of things, and purchasing how many boxes of gloves that the unit use in a day, in a week, in a month, etc. So those are things that are probably already tracked and already known, because they're worried about return on investment. And so that's sort of an easy place to start. And then if you pick a project that interfaces with something they're already measuring, then it doesn't necessarily generate a new dashboard. You just utilize the dashboard they're already doing. So I'm going to use maybe antibiotic stewardship is a good example of that. You probably are charting your infection rate versus, how draconian you are about limiting antibiotic use, et cetera. And so there's probably a lot of metrics around that are being already captured and dashboarded. And if you could figure out how to, maybe with a new initiative, I don't know, sometimes it's like moving to multi-dose vials instead of single-dose vials, and you would just be tracking, the life cycle of the multi-dose vial versus the single dose. I will mention, though, that you want to dashboard balancing metrics. What do I mean by that? Balancing metrics could be, if I start more severely limiting antibiotic use, let's say, to save time, money, effort, maybe my infection rate goes up. So I should certainly be tracking that. But let's say I go to multi-use vials from single dose vials. Well, I'm going to save on the packaging, et cetera, on a single dose vial. But if I have to gown and glove up, if I have to discard needles by multiply invading a vial, et cetera, I might be increasing inadvertently the use of a bunch of other stuff that I wouldn't have to use if it was a single dose vial. So, or I might have to do it under a hood. I might have to turn on the hood. I might use up electricity, blah, 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 blah. And so I think really thinking through the process with the process engineers as you're dissecting out kind of the life cycle impact of a change you would make. One example of that is a hospital sort of didn't think through things, and they went from disposable gowns to reusable gowns, thinking that they were doing a great thing of saving the environment. But it turned out two things: that the production of the gowns they were using was consuming and producing a lot of CO2. And the second was that the cleaning process that they involved for the reusable gowns actually created more CO2 and waste than actually using disposable gowns. So it's not always just like reusable versus disposable. It's really a thoughtful process of evaluating the dashboards that go along and including the balancing metrics, patient safety, quality of care, cost, and CO2 footprint. But right now in most of our dashboards, CO2 footprint is just not considered. It's not in the matrix and the dashboard.
Perfect. Thank you so much for that. I know you mentioned some examples of opportunities for stewardship already, like multi-dose vial, antibiotic stewardship, things like that. But there was still a question about maybe what are some other opportunities to be more sustainable within the ICU? Maybe
you're cutting a little bit in and out for me. I don't know if it's for everybody.
Yeah, I'm sorry. Yeah, I'll be closer to my phone. So I was just saying that you've already mentioned some opportunities for green ICU, such as multi-dose vial, antibiotic stewardship, but there was a question about maybe what are some other opportunities to be more sustainable within the ICU? Could you maybe give us some more examples?
Yeah, here's one. I'm so glad this came up because I forgot to mention it. So there's some things that maybe a dashboard. What do you think about a dashboard of where when you got to work, you were asked, how did you get to work? Was it public transportation? Was it a car? Was it a gas car or an electric car, etc.? And then you could have an anonymous dashboard that just protected for all the people that came to work in the ICU today. 75% of them took public transportation, 25 or whatever it is, right? That would be a dashboard. And you could say, let's challenge ourselves. Tomorrow that's going to be 74% or 76% or whatever it is. And you could be sort of aggregating and thinking about how that is. Like, what's the difference between 8-hour shifts and 12-hour shifts in terms of how many people have to transport back and forth to the hospital, right? So, of course, there's a consequence of a 12-hour shift versus an 8-hour shift that's, maybe have other consequences, but we have to, when we're thinking about it, we should put in the mix, thinking about how our scheduling, how our travel to work and from work, time of day, all of those things could be contributing to the carbon footprint and the greenness of our ICU. The SCCM is thinking about this. So for instance, we are moving our annual Congress to areas of higher concentration of population. And we are also moving it to areas where public transportation is readily available to get to the convention center, et cetera. And for the presenters and the faculty who are presenting at the Congress, we are no longer going to reimburse for airfare flights when they're in a radius of travel that would be more appropriate for like a train or public transportation. So that there will be like not forcing functions, but decisions to be made that hopefully will impact the environment in a good way and also be fair to the people who are participating. And those are like little things. Here's another thing we're thinking of doing. I mentioned, I think, quickly in the presentation of adding a caveat to every grant application that comes in to the SCCM for like a discovery grant, that you would have to address how your project is addressing the environment, how you've minimized the impact. What about the same thing for our journals, for pediatric critical care medicine, CCE, critical care explorations? If you had to report, just like you have to say, this was an institutional review board approved study, what if you had to report your lead rating for your manuscript? Like, how green was this project? It wouldn't eliminate any CO2. It basically would increase awareness and alertness and make people think about it as they're doing their projects, as they're reporting their results, as they're generating their grants, et cetera. And we think SCCM could kind of be a lead organization, a lean, green organization to try to promote that and model that to sort of lead for the future.
Perfect. Thank you so much for those examples. It's amazing how SCCM is, true to its words and taking actions to um, spearhead the Green ICU Sustainability Project. So I think there's a couple other interesting questions. One that was just messaged to me privately. How do you get both bedside and also stakeholders and leadership positions to be more aware of this topic and think about Green ICU and take into consideration?
It's a really good question. I don't know that I have great answers. I think it's very popular now. I think the administrators, et cetera, will be receptive, but they won't want to spend money on it. They'll want to, perhaps the best way, perhaps one way to do it is to have kind of a case example to be able to share with them, to be able to say, this is what we're doing, this is what we did, and it saved money, and it was safe, and it maintained quality. Because almost always when you talk about less is more, the pushback is, what does it do to our medical legal risks? What does it do to our CLABSIs, our patient safety metrics? Is it going to impact Joint Commission and our standing in the community? So there's always concern about safety and quality, and there's always concern about cost. And so by addressing those in kind of the case for support, or kind of the demo project that you do, I think you can get them more and more interested, because it's great PR for them if you're doing something about it, and they'll want to hear and invite you to present to them and to the board and everything if you have a small demo project that really worked.
Perfect. Thank you so much. There's still a couple more questions. Would you recommend seeing how other countries do more with um, less in order to implement those processes to be more sustainable? And which country would you think is at the forefront of sustainability to consider emulating?
So I think those are really good. That was how I became aware of it, sort of in my role as president. When I was going around to their different conferences, I was a little shocked about how far ahead they were than we are in general. I know there are individuals maybe out here who are very involved. I would say Australia and New Zealand are probably the world leaders in this. They were the first. They have so much buy-in in their units. They can't believe, like when I sit in on their meetings and talk about, like, I don't think the people in my unit know about this. They can't believe it. They've been doing it for like 10 years, and they say, like, when you look at their sustainability, how begin, it's kind of even more advanced than I would have imagined, because it's not really how to begin. It's like they didn't even think of putting awareness in as their first step, because like there's so much awareness. When you go to Seattle, for instance, and I don't know if any of you have traveled out to Seattle, but like the intensity of recycling, like your garbage person won't pick up your garbage if you mix anything recyclable with anything not. I mean, they're like militant about it. The awareness there is like really good. But I think I would say definitely Australia, New Zealand, and then the UK in most parts. The Netherlands also is leading. So those would be sort of the four spots: Australia, New Zealand, UK, and Netherlands. And I definitely think there's value in, traveling virtually or in person. It's always nice to go in person, but maybe virtually, to kind of understand what they're doing. And I have to admit that usually the pharmacists are ahead of everybody else in doing this, partly because I think they've been so aware and concentrating on antibiotic stewardship that this kind of like less is more is kind of in the culture already. Would you agree? Do you think that the pharmacists are kind of ahead of the game?
Yes, I would like to believe so.
Yeah.
A lot of our recommendations come from, being cost effective.
Yeah.
So, and also regarding antibiotic stewardship, obviously we want to do everything to prevent resistance. So yes, I would think that. And the next question is kind of related to the answer you provided. So, what would you run? What kind of data and charts can you run to capture these interventions that we do daily? Like, is there anything that we can track?
There are some really good examples. I have to say that I'm still a novice at this. I'm not an expert. I'm learning with you guys. We have formed a green team in our ICU recently. We are looking at that workbook, that sustainability beginner's guide. And in that, it's just a big PDF. It's not, and it's online and it's free and it's open. And it has a bunch of good examples, and they have an Excel spreadsheet that gives you little tracking ideas of what you can track. And I found that's really helpful. We haven't kind of decided on where we're going to focus yet in our ICU, but I would say if you glance, like, you don't have to read the whole sustainability workbook, but if you kind of scan that, and you'll find a couple of really good ideas for where you might. And it's probably going to be different for every unit. Like what you're tracking and what you're following as your metrics and stuff might be a little bit different in each unit. And so I can't tell you how time and cost effective it will be to piggyback onto something that's some sort of process assessment that you're doing already in your unit, and just add a little column about CO2 generation or something about the life cycle, and then it's sort of a tiny little add-on, and then people are willing to collect that data and display it for you, as opposed to trying to start an entire new thing. And sometimes it's as simple as just renaming something, like antibiotic stewardship and sustainability and green, whatever, because you're impacting it, and just it's a little add-on. And most people conceptually want to do this, they just don't know how to do it and aren't sort of feeling like it's their responsibility to do it, like they do with quality improvement or patient safety or measuring the other metrics.
Perfect. Thank you so much. Yeah, we'll make sure to share that document with everybody. It'll be available later on our YouTube channel and also seccmsc.org, our website. So thank you so
Yeah,
much for that. And I think that's it for all the questions that we have at this
that's
time.
great. I do want to mention that some of the people who opened my eyes, so Michelle D'Amico she's the co-chair of the task force for SCCM. She's a pediatric intensivist from California, Children's Hospital of Orange County. She unfortunately was ill today and couldn't join us. She was going to. She is doing a master's degree in sustainability, a distance master's degree, and she kind of brought this to us, to the society. And then also the folks at Houston Methodist Hospital in Houston, Texas, are doing some really great work. And some of their folks. So if you're like, you can visit internationally, but like Houston Methodist Hospital, I have no affiliation, no conflict of interest or whatever, but I visited them because they were kind of a thought leader and doing some good projects in this area. And so that's another thing that you could tap into. I don't know, it's probably not considered Southeast, it's probably deep South, but hey, it's close enough, and it wouldn't be hard to travel back and forth if you wanted to sort of get a taste of what they're doing out there. They're doing good stuff.
Yeah, perfect. That sounds awesome. Thank you so much, Dr. Nadkarni.
Great.
At this time, if there's no other questions, we'll conclude our meeting. Like I said before, this lecture will be available again on our YouTube channel. Thank you so much, everybody, for attending, and thank you, Dr. Nadkarni, for your time.
Okay, bye now. Good to see you
Bye.
all.
Good to see you.